Why traditional medical research leaves the most severe patients behind. A post-stroke perspective. Number 1325, August 10, 2025. EclaireMD Foundation. Gerald C. Category: Post-stroke perspective. Preface. This article weaves together three dimensions of my life: my scientific and academic training, my leadership of a billion-dollar semiconductor company, and my personal insights gained after surviving a recent stroke. My background includes mathematics, computer science, artificial intelligence, physics, various engineering disciplines, economics, business administration and people management, psychology, and medical science research. These disciplines have shaped how I solve complex problems, by looking at them from multiple angles. In my semiconductor career, I developed algorithms to place millions of transistors on purposed, integrated circuit chips and connect them with millions of wires. This required both a broad view and precise attention to detail. I had to balance academic theories with practical constraints to find the best possible solution. I also worked on the Space Shuttle program, which travels between space and Earth, and on intercontinental ballistic missiles launched from nuclear submarines. These same skills now guide my medical research. Instead of advanced machines and engines, sophisticated electronics and circuits, I now study millions of health data points, and their related hundreds of deadly human diseases. I apply the same systems-based approach to identify problems and design solutions for serious diseases, often without full reliance on drugs, focusing instead on pure pathophysiological study free from pharmacological influence. After my stroke on June 21, 2025, I noticed something unexpected. My thinking scope and analytical abilities became broader and sharper, especially in spotting patterns, interpreting research results, and discovering hidden reasons and connections from different perspectives. One powerful example came to me only recently. In the middle of the night, I suddenly realized that my former MIT advisor and lifelong mentor, Professor Norman Jones, had also built his engineering research around studying outliers. Extreme conditions, far beyond normal limits, such as crash loads, blast pressures, and structural failure points. Although I studied under him 50 years ago, I had never consciously connected his philosophy to my own medical research over the past 16 years. This late realization, 5 decades after my MIT years, is clear evidence of my post-stroke improvement in certain aspects of pattern recognition, and the breadth of my perspective. My mind is now better at linking concepts across time, spans and disciplines, allowing me to see unifying principles that were always present, but hidden from my earlier self. Summary: after reading or reviewing more than 8,000 published medical papers, I realized that much of medical research relies heavily on statistical averages. This works well for identifying trends in the general population, but it leaves out patients with the most severe conditions. The reason is not purely scientific, it is also economic. Large industries like pharmaceuticals, insurance, and processed food spend or donate large sums to fund medical research. They focus on the largest patient groups, because that is where revenues and profits are highest. After my stroke, my thinking, speed and perspective became sharper, wider, and more precise. I could see more clearly how economic interests shape today's medical research design, methodology selection, data interpretation, and ultimately, why the sickest patients get less attention. From a research viewpoint, not clinical viewpoint, I realize that in a capitalist society, even medical research is influenced strongly by money, not just by science itself. From my work in science, engineering, and medicine, I believe we must adopt both old and new methods, as long as they are effective in uncovering the truth. Examples include my viscoplastic medicine theory, VMT, and AI-based outlier detection. These approaches can focus on extreme clinical cases, and help identify early warning signs of serious diseases in the broader population. A simple explanation is that if medical research shifts from the average patient to those at the far edges of health resilience, we can save more lives. Main points: most medical research today is built on averages. Patients whose results fall far from the average, labeled as outliers or noise, are often excluded from statistical studies. To make the data easier to analyze and interpret, this practice also conveniently aligns with the financial interests of those funding the research. I now understand why some researchers have dismissed my work as personalized medicine. In reality, these outlier patients often face the highest risk of death, and hold valuable data and insights waiting to be discovered. Ignoring them means losing the opportunity to understand the most severe outcomes, and how to prevent them. Financial interests worsen this problem. Pharmaceutical, insurance, and processed food companies earn more by serving large, common patient groups. For example, by prescription volume, metformin is the most widely used medication for type 2 diabetes, accounting for about 45–50% of all diabetes prescriptions and reaching over 150 million users annually. In contrast, research on rare or severe cases offers relatively little profit, even though it can save lives. As a former CEO, I understand exactly what that means and how it works. My stroke changed the way I think. While I lost some short-term memory for things like street or food names, which do not significantly affect my daily life, my ability to connect ideas and recognize patterns has become sharper. I now see more clearly how medicine priorities, science, are often tied to industrial profits, economics, rather than to patient survival probabilities. Medicine. There are documented cases where brain injury unlocks new abilities. A phenomenon known as paradoxical functional facilitation. Some individuals suddenly develop skills in art, music, painting, or mathematics after brain injuries, including concussions and strokes. Case studies of Derek Amato, Jason Paget, Patrick Fagerberg, and Tommy McHugh illustrate how latent abilities can emerge through neuroplasticity, as brain cells and pathways reorganize. While most reported gains occur in creative fields, the same mechanisms can also enhance analytical thinking, pattern recognition, and the integration of different knowledge, particularly in individuals with a stronger data-oriented and analytical background, like myself. My post-stroke experience is somewhat similar to these observations. My specific gains have been in technical perspective and analytical thinking. In nonlinear engineering and AI modeling, we always test for extremes. The rare cases that can cause a system to fail. My training at MIT taught me that a design is only as good as how it performs under the most extreme stress. My recent realization about Professor Norman Jones's work reinforces this. His lifelong engineering research focused on dynamic, viscoplastic material science under extreme conditions. Crashworthiness, blast protection, and structural resilience. These are all about understanding the limits of a system, not just its average performance. That same philosophy now drives my medical research work. Just as engineering must prepare for rare, but catastrophic events, medicine must study patients at the far edges of the clinical spectrum. These outliers reveal the true limits of human health, and understanding them is essential for creating prevention, treatment, and recovery strategies that protect everyone, not just the statistical majority. The VMT model and AI-driven outlier, big data analysis bring advanced engineering and computer science into medicine. Instead of discarding extreme data, we can treat it as an important warning sign of what may happen to others. This offers two major benefits: better predictions for high-risk patients, and a deeper understanding of the boundaries of disease. Recommendations. 1. Require outlier analysis and research. Study and report extreme cases, not just averages. 2. Encourage advanced modeling. Support research that models the human body as a nonlinear, dynamic, irreversible, and complex system that accurately reflects the real-life behavior of living cells of human beings. 3. Limit industry's financial-based bias. Reduce profit-driven attitude and its influence over which studies get funded. 4. Use engineering and AI tools. Apply methods like VMT, rooted in principles first developed by Isaac Newton about 400 years ago, and neural network outlier detection, a more modern tool from about 50 years ago, to find early signs of danger in high-risk patients. By making these changes, medical research can move from serving only the majority to protecting everyone, especially those most at risk.